Good afternoon, everyone, and welcome to the BPS Research Spotlight Series. Today's presentation and discussion will focus on a recent pediatric critical care medicine publication entitled Trends in Time to Extubation for Pediatric Postoperative Cardiac Patients and its Correlation with Changes in Clinical Outcomes, a virtual PICU database study by Drs. Epstein, Olinger, Shevis, LA, and Shein. The study today will be presented by its primary author, Dr. Rebecca Epstein. Dr. Epstein completed her pediatric residency at Case Western Reserve University Rainbow Babies Children's Hospital in 2020, and she is currently the Chief Fellow in the Division of Pediatric Cardiology at Columbia University, New York Presbyterian, and Morgan Stanley Children's Hospital. One of her co-authors, Dr. Stephen Shein, Chief of Pediatrics Critical Care at the University of Hospitals Rainbow Babies, is also with us online today. We will have questions at the end of the presentation, so please put those in the chat box and we will screen those and try to answer as many as we can at the end of the presentation. With that brief introduction, we'll move right on into the presentation by Dr. Epstein. Rebecca?
Okay, great. So you should see my cover screen for my slide at this point, but obviously let me know if you don't. All right, so nice to meet everyone. Thank you so much for having me, and it's really a pleasure to be here. So as Dr. Rice mentioned, I'm currently a third-year Peds Cardiology Fellow at Columbia. And I wanted to share with you a research project that I conducted with Dr. Shein during my pediatrics residency at Rainbow Babies and Children's Hospital in Cleveland using the BPS database. And as you can see on my cover slide, the project was entitled Trends in Time to Extubation for Pediatric Post-Op Cardiac Patients and its Correlation with Changes in Clinical Outcomes. And our study was published in PCCM this past summer. I have no conflicts of interest to disclose. So just to start with a little bit of background, invasive mechanical ventilation plays a critical role in children recovering from heart surgery. There's pros and cons to mechanical ventilation. So it helps to maintain adequate oxygenation and ventilation postoperatively and to decrease work of breathing. From a cardiac standpoint, mechanical ventilation we know can be helpful by decreasing left ventricular afterload and by decreasing the overall metabolic demands that the heart needs to meet. However, we also know that mechanical ventilation can be associated with negative sequelae, such as, ventilator-induced lung injury and infection, and increased exposure to sedative medications. And so with this as a background, in recent years, there's been a movement kind of on a national level to decrease the amount of time that children remain intubated after their cardiac surgeries. And because of the potential benefits of early extubation, there's been consortiums such as the PHN Pediatric Heart Network Collaborative that have implemented clinical practice guidelines to promote early extubation after selected cardiac surgeries. So on this slide is a paper which published the PHN Collaborative's findings back in 2016, which you can see highlighted here in the results section showed that implementing the CPG or clinical practice guideline to promote early extubation increased early extubation rates. And you can see at the end here, though it wasn't statistically significant, they did mention that the decrease in duration of mechanical ventilation was associated with the trend in, improved ICU length of stay after the specific operations that they studied. Not on this slide, but just to mention, there's been other single center reports in the past decade that have really demonstrated early extubation has been associated with favorable outcomes like decreased ICU length of stay and also decreased hospital length of stay. So based on this data and other research showing that early extubation is often feasible in children undergoing cardiac surgery, there was a recent 2021 consensus statement that was put out by the American Association for Thoracic Surgery that I highlighted here. One of their recommendations was that they emphasized that early extubation is, quote, an integral component of ERP, so their enhanced recovery postoperatively in children following heart surgery. What was still unknown and kind of sparked our research project was kind of two questions. Number one, we knew that there had been a growing emphasis on early extubation kind of on a national level, but we were curious to know what the actual recent national trends were in early extubation rates. We also wanted to know, not just on a patient level, but on a center level, do centers that more commonly practice early extubation have better severity adjusted outcomes? So our aim was really to describe the trends in early extubation rates over time and to evaluate if a center's early extubation rates were associated with improved clinical outcomes in children undergoing heart surgery. VPS for us was kind of the natural choice of where we went to. We were looking for a large multi-center database, which, you know, of course, VPS is as the largest collaborative PICU quality improvement database. And it, you know, VPS has been used to support previous research in children recovering from cardiac surgery as well. So in terms of who we included in the study, we studied children in the VPS database who were less than 18, who were admitted between 2009 and 2018 and had an operative cardiac procedure either directly prior to or during their ICU admission. We excluded all heart transplant patients or patients who had a tracheostomy before their cardiac surgery. We also excluded patients who did not have a documented STS cardiac procedure. So the STS case index, which is used to identify the type of cardiac surgery, is not a mandatory reporting field in VPS. So our data was limited to centers who reported that information. We also excluded patients who were missing endotracheal intubation procedure start or stop times, or patients with irrational data. So turning to kind of a little bit more of our methods and study definitions. So if we look at a typical timeline for a child having heart surgery, their hospitalization usually starts with them being admitted and kind of going straight to the operating room, after which they're admitted to the PICU to recover. Early extubation has been previously defined in the literature as removal of the ET tube before or within 6 hours of arrival to the PICU following surgery. So for consistency, we use the same definition. There were a few things that we needed to consider specifically when using VPS for this analysis. The first is that use of an ET tube only while in the operating room is not collected in VPS. So subjects who had no intubations at all reported in their database were considered to have undergone early extubation by the anesthesia team prior to PICU admission. An additional consideration was that, you know, for most children, they're only admitted to the ICU after their cardiac surgery. In VPS, times of all events are referenced to a time 0, which is the time of initial admission to the PICU. So for most patients, surgery start time is given a negative number in VPS. So the example I put here is -4 hours. And these patients have an exactly known post-op ICU admission time and an exactly known extubation time. So we could pretty easily determine whether or not these patients were extubated early. However, there are a small number of children who get admitted to the PICU preoperatively, usually because they're critically ill and need to be medically stabilized before surgery. For these children, their cardiac surgery start time was reported in VPS as a positive number relative to their PICU admission time. So the example I put here is positive 3.23 days. But the exact time that they return to the PICU post-operatively is not available in the VPS database, which, as you can see, is an important piece of information that we needed to use to determine if they were ultimately extubated early or not. The way that we dealt with this problem is that we used the other patients for whom we had an exactly known surgery time to estimate the surgical duration and therefore the postoperative PICU admission time for children who were admitted to the ICU before their cardiac surgery. So going back to our prior example, for a child who was admitted to the PICU preoperatively, okay, if that patient underwent a RACS-3 procedure, and just to briefly review, RACS is a scoring system that categorizes cardiac surgeries based on their complexity and risk of perioperative mortality. So if we had a patient with a RACS-3 procedure with a reported start time, with a reported surgical start time of 3.23 days, that patient would have an estimated post-operative PICU admission time of our average RACS-3 score surgical duration was 0.27 days. So we would add that to the surgical start time to come up with our post-op PICU admission time. and then use that as part of our calculations to figure out if a child was extubated early or not. So for example, this patient, based on our estimation, would have come back to the PICU at about 3.5 days and was extubated at 4.0 days. So would have been considered to not been extubated early. Early extubation rate at each center during each individual study year was calculated. To determine a center's early extubation rate, we only included children undergoing the low to moderate complexity surgeries at that center, so RACS 1 through 3 procedures. And really the reason why we did that was, higher complexity surgeries don't allow as easily for early extubation and weren't performed equally at all centers. And then for each study year, each center was categorized into one of the following quartiles: either very frequent early extubation, so more than 62% of their low to moderate complexity surgical patients were extubated early, and then frequent early extubation, common early extubation, and then an uncommon early extubation group where less than 38% of those patients were extubated early. The primary outcome that we looked at was rate of early extubation over time. And then as a secondary outcome, we identified associations between early extubation and the clinical outcomes of mortality and ICU-free days in a 28-day period. And then for the ICU-free days, a value of 0 for children who died or had a PICU length of stay that was greater than 28 days. We also performed a sensitivity analysis. So our analyses were repeated after excluding subjects with that estimated post-op PICU admission time, and we recreated our models. Okay, so on to the results. So this is our figure 1, just going through subject selection and exclusion criteria. So as you can see here, of the original VPS data set based on the inclusion criteria that we set, there were a little over 73,000 patients. And then a little over 3,000 patients had to be excluded based on our exclusion criteria. So we had nearly 70,000 subjects included in our final analysis. So among all subjects, okay, so this is looking at all subjects in all centers, there was no significant change in early extubation rates over time. And this specifically was for centers with at least 8 years of data. So what you can see here is that in 2009, the early extubation rate was 48%, and it was nearly identical in 2018 when the early extubation rate was 47%. There was also no significant change in early extubation rates when stratifying subjects by the center volume size. When we stratified subjects by their RACS score, which you can see on the left here, or by their age, RACS class 3 subjects and children 2 to 11 years of age had statistically significant changes in their early extubation rates over time, but the absolute differences were small. So this table looks at our univariable and multivariable analyses of factors associated with PICU-free days. So in univariable analysis, hospitalization in centers that more commonly practiced early extubation was associated with favorable, more PICU-free days. And as you can see here, in pairwise comparisons, uncommon early extubation centers had fewer PICU-free days than each of the other 3 groups. And the very frequent early extubation centers had better, more PICU-free days than each of the other 3 groups. Weight, center volume, discharge year, RACS score were also associated with PICU-free days, and so they were included in the multivariable logistic regression model. So after adjusting for these covariates, hospitalization in a very frequent or common early extubation center was not associated with more PICU-free days compared to hospitalization at an uncommon early extubation center. This next table reports the univariable and multivariable analyses of factors associated with mortality. So just zooming in on the key findings here, mortality rates did not differ significantly between the 4 early extubation groups, either in the univariable analysis or after adjusting for potential confounders in the multivariable analysis. And then it's not included on the text of this slide, but just to say for our sensitivity analysis, when children with those estimated times of ICU admission were excluded and the models were recreated, Early extubation groups continue to be associated with PICU-free days in univariable analysis. And then in the multivariable analysis, common early extubation was associated with better, more PICU-free days, though the absolute improvement was small with an increase of 2.5%. But neither frequent nor very frequent early extubation centers were associated with an improvement in PICU-free days. And in this subgroup, we also showed that early extubation was, again, not associated with changes in mortality. So in this large multi-center database of critically ill children who underwent cardiac surgery, we had a couple of main takeaway points. One was that early extubation rates haven't significantly changed over time. And that was kind of no matter how we slice the data. So regardless of age, surgical complexity, or center volume. And then the second finding was that centers that more commonly practice early extubation among their lower complexity patients had no improvement in their ICU length of stay or mortality after adjusting for center and patient level variables. So, although the reasons why early extubation rates have stagnated can't be answered by our study, I think it is important to consider what factors could have influenced this trend. So some possibilities are that, in the past decade, there's been an increasing performance of more complex surgeries that maybe wasn't adequately captured in the RAC scoring system. Another possibility is, the difficulty of sustaining early extubation practice algorithms. So I showed on one of the earlier slides that there's been movements to improve early extubation rates with new clinical practice guidelines. Studies have shown that temporarily improves early extubation rates, but follow-up studies actually showed that in the long term, most centers reverted back to their initial early extubation rates. So that may be contributing to the lack of improvement in early extubation rates over time. And then, another important reason why rates may really not have increased is the lack of data on a center level proving that it improves outcomes. The strengths of our study included utilization of VPS. So it allowed us to use a very large sample size and subjects from many centers over multiple years, and that we were able to focus on center level outcomes. The limitations of the study, there are likely factors that differed between centers that we weren't able to adjust for, although what we did know of as potential confounders were included in our multivariable analysis. There's always going to be an inherent risk of inaccurate data entry, but the VPS database really tries to minimize these errors with strict quality control. And then the large sample size with almost 70,000 subjects can help offset probably most of those inaccuracies. Next, the STS case index, which is used to identify the cardiac surgery in the database, isn't a mandatory reporting field in VPS. So our data were limited to centers who reported this information. So ultimately, it ended up being 2,500 subjects who were not included because they had no listed STS case index. And then for children who were admitted to the ICU pre-op, their surgical end time, like I mentioned, really had to be estimated, which might have led to some improper characterization of which patients were extubated early, although our findings were mostly reproducible when using only data from children with known surgical end times. So, taking all of these discussion pieces together, the overall conclusion from our research, or my overall conclusion, was that these findings really don't support that clinical outcomes can be improved further by further increasing early extubation at the center level. So in terms of publication and impact, so our findings were published, as I said, in PCCM this past summer. There was also an editorial that accompanied our publication. And so I just kind of highlighted and wanted to mention some of the points that they brought up as what they felt were kind of some conclusions from our study. So one of them is, kind of at the bottom of this paragraph here, they had mentioned that in the context of the overall improved outcomes of post-cardiac surgery patients, the lack of significant change in early extubation rates over the last decade indicates that allocating additional resources to enact change may not confer additional benefit. And also that the discipline is likely already doing well in the realm of early extubation, and that it may be helpful to focus our attention on other aspects of postoperative care. I think, reflecting on the research that we conducted, my takeaway is that, early extubation, when medically safe to do so, does play a critical role for children who are recovering from their heart surgeries, and that we should continue to have active discussions for every individual patient, but also on the center level of how to ensure that we're extubating children at the earliest possible time. I just think that in the past decade, there had been kind of this movement to improve the rates of early extubation, with the hope and the potential that early extubation could be this holy grail for, improved clinical outcomes in these patients. And I think from that standpoint, early extubation hasn't proved itself to be that holy grail, that easily targetable intervention that would have a clear translation into improved clinical outcomes. That being said, it's still a very important part of, postoperative care in these children, and is still important as part of the bundle of care that we provide to these patients. So thank you so much for your time. And I wanted to open the floor to some questions.
Thank you, Dr. Epstein. There is a couple of questions from Dr. Markowitz, and he thanks you for a great study. Then he asked, do you track the numbers of large centers over time? As we know, almost all large centers have moved from VPS to PC4 in recent years, and it may be more likely that the larger centers are more, quote, progressive in early extubation. And then he has a secondary question that's asking, it should be highlighted that the last year of the study is now 5 years old, which may have changed some of the numbers since then.
For sure. So thank you so much for your question. So to answer the first question first, so we did look at center case volume. For early extubation rates, each center had a different categorization per year, which is not what we did for center case volume. So what we did was, just to give simple numbers, if you submitted 100 cases over the 10-year period and you submitted 10 years worth of data, then we just divided your total cases by the number of years and just said that you had 10 cases per year, and then sort of designated your center size based on that. So you kind of each center had the same designation in terms of volume size throughout the entire study period. So it's a good point that, even if they are a large center, whether they would be considered a large center in our study may have actually changed just based on how much data they were actually submitting to VPS versus a different system. And then the other comment about our study period ending in 2018. So we had kind of been back and forth about whether or not to include additional years. I think we were considering adding more, and then COVID kind of hit, and we weren't sure how that was going to impact any findings in terms of early extubation rates. So that's why, recognizing that the data is a couple of years old, we didn't want to include the more recent data that may have been impacted by the pandemic. But, we recognize that's one of the limitations.
Thank you, Rebecca. I see Dr. Shein is here. Steve, do you have any comments to Barry's question?
Yeah, so first off, Dr. Epstein, awesome job with the presentation, and thanks everyone for the invitation and for listening today. So just to reiterate what Becky said, so 80 or so centers in the study, all of them were classified as either small volume, medium volume, or large volume for the entirety of the study. So there was no dropout. Though Barry's point about that certain cardiac ICU programs have moved from VPS to PC4, and that those might be more aggressive centers is certainly well taken. And then the data, that was troublesome because we went back and forth about whether or not adding data from 2019, 20, and 21 would be helpful, or whether it would just sort of muddy the water, since COVID certainly might have had some direct and indirect and even unmeasurable impact on the practices. So it's it's one of the major limitations, I think, of kind of how to use these data going forward, and sort of moving into some of the stuff Gerardo asked, that these data are now, a solid 5 years old. Tom, you're on mute.
All right. Thank you, Steve. Becky, Dr. DeSoto Campos has asked a couple of questions. So even though your study showed no change in early extubation rates, were you expecting to see a change? And if so, why? And then he has a secondary question. Would it be safe to conclude that this study shows that any QI efforts to reduce early extubation rates might be useless?
Yeah, so I think to your first question, I actually was expecting to see a change and I was quite surprised when we didn't. I think we all know that there's often trends within data and quality improvement. And I think about 10 years ago, or maybe 7 or 8 years ago, there was a lot of attention given to early extubation rates, improving early extubation rates. And when the initial studies of like single center reports came out that improvements in early extubation rates were associated with shorter hospital and ICU length of stay, my thought was that centers were going to kind of more aggressively hop on that bandwagon of really putting their eggs in the basket of, hoping that early extubation and improving early extubation would translate into improvements in clinical outcomes. So I expected to see a change and I didn't. So it was surprising for me. I wouldn't go so far as to say that QI efforts to reduce early extubation rates are useless. I think we certainly know the benefits of being able to extubate children as soon as it's medically safe to do so. And so I think for that to always be on our mind as a medical community is critical. I think kind of putting on blinders and really honing in on early extubation rate as the answer to, changes in clinical outcomes, that's probably not realistic. But, I think thinking about early extubation as part of the bundle of care that we provide for patients. And so if it's part of this bundle of care of improving early extubation rates and other important, factors in a child's postoperative ICU stay, I think certainly there is potential for it to translate into really meaningful changes in clinical outcomes.
That's
Yeah,
great.
and I totally agree. I was expecting to see an improvement when we got the data. I think it's a good example of that we don't always do what we say we do. Because I think if you had asked, 100 people that are intensivists or cardiologists, the majority would say we've gotten better with this over time, and the data show that we haven't. But I very much agree with what Dr. Epstein said. The fact that our data don't support that centers that early extubate do better doesn't refute that actually might be the case. Like, this is a database study. It's supposed to be hypothesis generating. So I don't agree that this is like the end of QI work to help improve early extubation at the center level. It's, it was not the nudge, the supportive nudge in that direction that we were anticipating and kind of hoping it would be. But the absence of evidence is not the evidence of absence.
Well, we are at our time limit. I want to thank you, Dr. Epstein, very much for taking the time to give us this information and to give us the opportunity to ask a few questions. And also thank you, Dr. Shein, for participating in this exercise. That concludes our meeting for today, and hope to see everybody at our next presentation, which will be 3 or 4 months from now. So thank you again to our speakers.
Thank you for the invite, and thank you for everyone's attention.